On behalf of the ACHSC and UCCC team, thank you for coming tonight. We are pleased to see such a great turnout. I am Aisha, and Jess is also on this call. We are the co-directors of this year's University Cancer Case Competition, or UCCC for short. Tonight we are proud to present to you UCCC 2020 Information Night.
For those of you who heard of it, UCCC is an initiative of the Australian Cancer and Health Sciences Competition, or ACHSC. We're a not-for-profit and student-led organisation dedicated to nurturing a future generation of cancer-literate people who are empowered with the skills and knowledge necessary to reduce the burden of cancer in our society. UCCC aims to provide an opportunity for university students to critically analyse the state of cancer research, prevention and treatment in today's global society.
Before we start, we would like to thank our partners, the Victorian Comprehensive Cancer Centre, the Melbourne School of Population and Global Health, the Gene Technology Access Centre, the Walter and Eliza Hall Institute for Medical Research, Cancer Council Victoria, and the Olivia Newton-John Cancer Institute for their support, Tour de Cure and Breast Cancer Network also.
Tonight, we'll be introducing the theme of UCCC 2020, Cancer Survivorship. Your task is to devise an updated model of care for cancer survivors who have completed active treatment. More information about the task can be found in the UCCC case file document written by our amazing research officers Nock and Josh, and more details about UCCC itself can be found in the guidelines document. The link to access them will now be sent into the chat.
To give you a well-rounded overview of this topic, we have invited experts in the field of cancer survivorship to present tonight. Due to COVID-19, we were unable to hold this event in person, but our guest speakers have recorded their presentations, which we'll play for you tonight to view.
Before we begin, your feedback on Info Night 2020 is valuable to us. If everyone could please fill out this evaluation survey by the end of tonight's event, that'd be amazing. The link for this will also be sent into the Zoom chat now. Everyone who completes this will be entered into a raffle for a $25 Uber Eats voucher, which will be sent at the end of tonight. I'll now pass on to our logistic officers, Amy and Minji, to introduce our guest speakers.
I would now like to present our first speaker, Meg Rinderman, who has a lived experience of cancer survivorship and is a consumer advocate for the Australian Cancer Survivorship Centre at Peter MacCallum Cancer Centre. Meg also works with Cancer Council Victoria and is a Cancer Connect peer support volunteer.
Thank you for inviting me to join you. My name is Meg Rinderman. Before I begin, I need to explain that words are very important to me. I think deeply about what I want to say, about the message I want to impart whenever I tell the story of my cancer journey. I write it down, and if you'll bear with me, I'll share my words with you. I told my story for the first time at the launch of the Australian Cancer Survivorship Centre at Peter MacCallum in 2010. I commented that friends had told me I was so lucky. Lucky that Hodgkin's was the best cancer to have. Lucky that radiation was so much better than chemo. Mine has been a cancer journey spanning more than 25 years, starting with a diagnosis of Hodgkin lymphoma, followed with increasing severity by 2 recurrences and a breast cancer diagnosis requiring a double mastectomy and reconstruction, and recently a recognition of something anecdotally referred to as breast implant illness. Tests, biopsies, scans, aggressive mantle radiotherapy, high-dose chemotherapy, apheresis, stem cell transplant, hormone therapy and surgery, each of them promoting a kaleidoscope of reactions and side effects, often requiring hospitalisation. My companions, a formidable array of chemical compounds with intimidating names, usually accompanied by gloved, gowned and bespectacled attendants. Today, I'm well and cancer-free. Invariably, a lingering headache, a persistent rash or any ailment not easily diagnosed will lead to a regimen of cautious testing with unspoken concern around recurrence or secondaries. Ongoing side effects and late effects are things that are skated over, never considered in the immediacy of diagnoses, treatments and surgeries. A mental scan of my body today, though, would reveal weariness as a constant companion, menopause for the third time with all of its attendant side effects, vaginal dryness making intimacy painful, nightly violent cramps in my feet and calves, peripheral neuropathy and post-mastectomy discomfort. I experience loss of breath walking up hills. Esophageal scar tissue often causes violent coughing, and morning showers taking longer to warm bones and ease my body's stiffness. All of this covers the physical and doesn't take into account the emotional and psychological. My libido has virtually disappeared, and the strain that places on my partner and I is marked. I live much more in the moment, take each day as it comes, make the most of it, and don't project too far into the future. I'm more self-contained and comfortable in my own space. Most of this is related to my various cancers and their side effects. Some, though, I'm sure, due to the fact that I'm now 70 and feeling my age. I'm vigilant with my screening checks, and I'm sun smart. I'm aware of and listen to my body. I use yoga breathing to help me when I walk up hills. I go to Pilates, walk regularly, eat healthy food, and when I remember, meditate or do my relaxation exercises. That's my new normal, and I'll take it any day rather than the alternative. My husband and I ran a family business. Staff and deadlines needed attention. He held it together, supporting both me and our children, wiping my fevered brow, as he referred to it, fielding the phone calls and often intrusive inquiries, covering for me when I was too sick to be at work. His life has changed along with mine. Not only has he supported me through my lengthy journey, but has also been impacted by my treatments and side effects, my changes, both physical and psychological, all the while quietly worried about those unmentionable what-ifs, concerned if I'm pale or tired, or wince when I stand up or move. Over the years, people have directed their concerned questions about me to him. Rarely has anyone asked how he is feeling or whether he might need some support. His life has changed in equal measure. My 3 children, now parents themselves, were so young when it all began. The impact on every aspect of their lives has been enormous. They've shared with me their unconditional love and support, ensuring through the laughter and the tears, through the minutiae and normality of everyday life, that I was able to maintain a sense of perspective. They helped me not to be overwhelmed, but to retain a constant focus on what was important in my life. Each time, family and friends stepped in with care and assistance. How lucky I was. These days, my best medicine is to spend an afternoon with one of my beautiful grandchildren, whose kisses and cuddles ease away anything that ails me. I spend a great deal of my time in a voluntary capacity as the consumer representative of the Australian Cancer Survivorship Centre, as a patient advocate, and as a volunteer for the Cancer Council's Peer Support Cancer Connect program. In order to put a face to cancer survivorship, I tell my story often as a tool to inform, to educate, and give hope. Doctors, nurses, technicians, students and others now have a fuller understanding of what life is like post-diagnosis and treatment. From my own experience, and anecdotally from conversations with other cancer patients and survivors, I'm conscious of the giant capital C that is seared onto one's forehead as soon as the words, "I'm afraid you have cancer," are uttered. From that moment, you're no longer Meg or Steve or Joan. You become a generic. You become the cancer patient. For everyone around you, it's as if the rest of your life fades into the background, all of its elements dwarfed by this massive thing that's happening to you. And in many instances, that's how we, the cancer patients, are viewed by those who deal with us professionally. Their focus is on treating and dealing with that oversized C. So perhaps sometimes it's easy to forget that we're whole human beings with lives, families, jobs, interests, problems that now live concurrently with our cancer diagnosis. During treatment and at its conclusion, we have to deal with and return to these lives and their attendant complications. A simple, "How are you today?" or "What else is happening in your life?" would often suffice. Attention is needed, a listening perspective adopted to learn what are the stresses and complications of each patient's life and direct them to the supportive care that they need, to support them not just through the acute phases of diagnosis and treatment, but also to follow them home and support them where necessary for the remainder of their lives. At Peter MacCallum, the term survivor is used to describe all cancer patients from the point of diagnosis. Each individual cancer journey and survivorship is unique. Not everyone diagnosed with cancer relates to the word survivor. We all have differing responses to that moment of discovery, that initial diagnosis, to our testing and treatment, our support network, our recovery, our survivorship. But there are aspects that we all share and which we recognise and acknowledge in others. The hesitant yet triumphant walk to the front gate and later to the corner of the street. The meal no longer accompanied by the metallic taste of chemo. The milestone, the special birthday, being present to walk a child down the aisle or hold a brand new grandchild. The moment of return to school, to study, to work. The stumbling conversation with work colleagues and friends who don't quite have the words. The realisation that new normal has implications in all aspects of our lives. The way we look, the way our bodies function or don't. The changes, both physical and psychological. The way our memory can be triggered by a sound, a smell, a scene in a movie or a play. Many of us are inspired by a need to give back, to help others in some way. We live very much in the moment, an accompanying whisper in the back of our minds before annual checkups or the investigation of a new symptom. We're conscious of the concern of our family and friends, their fear around the what-ifs. But for each of us, the thing that defines survivorship is the simple fact of waking up each morning to embark on the journey that is the new day. I often use the word lucky with a sense of irony and not a little sarcasm when I refer to my own cancer experiences. Lucky to have gone to the well so many times. Lucky to have suffered the side effects and late effects. Lucky to still be here? Absolutely. I've reflected often on that luck and thought about how privileged and lucky I truly am. I've thought about the hundreds of patients I met in my time coordinating the Wellbeing Centre at Peter Mac and the thousands I'll never meet. These survivors, and the many others I've actually encountered, each struggle with their own particular issues. Often, they're not so lucky. English may not be their first language. They may be overawed by the hospital or by their treating team. They may lack education and be unable to understand the complex terminology surrounding cancer. There may be no word in their own language to describe what's happening to them. Their treatment may be complicated by the huge distances they have to travel. Work issues and financial difficulties may compound their concerns around diagnosis and treatment. Worry about who will look after their children, their pets, their business may fill their waking hours. The fear of their cancer coming back may be overwhelming. They may not have a regular GP. They may have no support network of their own and slip through the gaps of supportive care if it's available. And this is where I become passionate. This is my particular soapbox and the focus of the advocacy in which I'm involved. Cancer is still regarded as a one-off incident rather than a chronic disease. Distress thermometers, needs assessments, and the other tools of supportive care assess how patients are travelling. Survivorship care plans, peer support, helplines, and a plethora of information are becoming available. And there's currently an emphasis to relieve the load on the hospital system with patient-centred shared care and telehealth. These need to be valued and funded to assist patients throughout their lives. Survivors' voices need to champion all these measures, agitating too for the creation of seamless communication between the cancer hospitals and GPs. All of this will ensure that survivors feel their progress is being monitored and managed efficiently with concern and empathy. It feels timely to tell you my story in a time of lockdowns resulting from COVID-19. During this time, our lives have been circumspect and contained, our interactions conducted on screens. Our healthcare professionals have become nimble and offered their patients innovative solutions with telehealth, home treatment and shared care. I'm reminded of the patience required, the slowdown imposed by treatments and their side effects, the remoteness of transplant, the isolation necessary when immune compromised, the understanding that for me, taking one test, one diagnosis at a time was what was required to compartmentalise the enormity of that thing called cancer. UCCC 2020 places each of you into a unique position to effect change, to smooth the rollercoaster ride of cancer survivorship. I am indeed lucky to have been given the opportunity to find my voice as a survivor, hopefully to use that voice to assist other survivors find theirs and help to change the system to make their ride on the roller coaster a smoother one than mine has been. Thank you.
I would like to thank Meg for her powerful words. Our next presenter is Professor Michael Jefford, who is a consultant medical oncologist and director of the Australian Cancer Survivorship Centre.
Hi there, I'm Michael Jefford. I'm a medical oncologist at Peter MacCallum Cancer Centre, and I'm also director of the Australian Cancer Survivorship Centre based at Peter Mac. I've been asked to speak a little about cancer survivorship in general, as well as the issues experienced by cancer survivors, and also to speak about the Australian Cancer Survivorship Centre. Today, I'll cover who is a cancer survivor, some common issues experienced by survivors, some of the issues with current care, some guidance around ideal care, and then talk about the Australian Cancer Survivorship Centre, or ACSC. So who is a cancer survivor? We use the term to describe different populations, but most commonly we think of survivors as people from diagnosis onward for the remainder of their life. The survivorship phase is often described as that time after completing initial treatment for cancer. And it's a phase that deserves much more attention and focus. The term survivor doesn't resonate with everybody, and some people don't really like the term. And we often talk about living with and beyond cancer or life after cancer. In Australia, in 2014, there were estimated to be about 1.1 million people with a personal history of cancer. That's about 1 in 22 all Australians are a cancer survivor. We know that this number will increase substantially because of the ageing population, increasing cancer detection, and improving survival rates. At the moment, about 68% of people are expected to survive 5 years beyond diagnosis. By 2040, we estimate there'll be about 1.9 million people in Australia who are survivors. The majority of those people will be long-term survivors, that is, over 5 years since diagnosis. And the majority also will be over the age of 70. And we know that the majority of survivors have comorbidities, and that's important when we think about ideal models of care. The most prevalent groups are people who have survived prostate cancer, breast cancer, colorectal cancer, and melanoma. We know that the majority of people adjust well to life after cancer. We shouldn't over-pathologize the post-treatment phase, but there are a set of issues that are extremely common and common across cancer diagnoses. So regardless of whether people have had treatment for bowel cancer, prostate cancer, breast cancer, etc., there are a common set of issues. We certainly know that many people, report quite varied reactions after finishing treatment. So some people are quite happy and excited and relieved the cancer treatment has completed, but many people can feel quite lost and abandoned, particularly if they've had quite intense engagement with the treatment team. There are a range of side effects after finishing treatment, and these include issues like fatigue, pain, concerns with sleep, as well as altered cognition. There are common emotional and psychological issues, and particularly the worry about cancer coming back. There are side effects that can develop later. We could refer them to these as late effects, and that could include the risk of becoming infertile, the risk of organ damage because of cancer treatments, and also the risk of developing another cancer because of cancer treatments. There are also impacts on family members and friends, as well as practical issues such as difficulty getting back to work or study and financial consequences. We know that people can have impaired earning ability for the remainder of their life. Having said that, people do sometimes report benefits through the cancer experience, and certainly having cancer and going through cancer treatments is a major shift in has a major impact on life, and it makes many people reassess things as a result. In terms of current survivorship care in Australia, this tends to be medically led and tends to have a focus on the detection of cancer recurrence and the detection of possible second cancers. We know that there's a non-systematic inquiry about current and potential issues. Having said this, it does tend to be reassuring for patients. It's often pleasant for clinicians, though we know that many issues aren't identified and not addressed. This is some data from a medical student who did some work with us over the last couple of years, and she looked at how follow-up is documented. And so she looked at the documentation following clinical review for people who had been treated for colorectal cancer. And she found that some aspects were very well documented. So if we look at new symptoms since last review, almost always this was commented on the review. Likewise, testing such as CEA tests, CT results are very commonly documented. Likewise, documentation of physical changes, well documented. But if we look at other areas about wider survivorship care, discussion of the need for screening for other cancers, not at all reported. Discussion of psychological changes, very rarely. And the need for regular health checks and other health screening not noted at all. And so we know that the current pattern of care does seem to have some deficiencies. We know too, survivors are often, as I mentioned, are often unprepared for the post-treatment phase. They may be unaware of health risks. They often have symptoms and other issues that are under-recognised and under-treated. Many people report that they have too many and poorly coordinated review appointments. So they may be coming back to see multiple oncologists without any real consideration for whether they've had another review. Sometimes people are having multiple reviews in the same week or the same month. And for some people, they travel long distances for these reviews. There's insufficient focus on health promotion and attention to risk factors. We know that many survivors continue to have poor health behaviours in terms of smoking, they're not exercising enough, other risk factors that aren't really being inquired about and responded to. We know too that specialist-led reviews are probably not the best use of their time, and multiple reviews can limit the ability to see new patients promptly. Likewise, primary care providers, including GPs, are often not adequately engaged in the care of cancer survivors, and they often don't have the information and the support that they need to optimally manage the care of cancer survivors in the community. There can be an underuse of existing services, and although we probably don't have as much cancer rehabilitation services as we might like, often these services are underutilised, and that's true too for non-government organisations and not-for-profits in the community. There's also an underuse of nursing and allied health-based reviews, both in the oncology setting and in primary care. And at the moment, we have limited metrics and limited key performance indicators to describe and report and to drive optimal care. So this report, From Cancer Patient to Cancer Survivor Lost in Transition, came from the US, from the Institute of Medicine. It was published in early 2006. And it really shone a light on the issues that survivors experience. It came up with a set of recommendations and also broad essential components of ideal care. And they're listed in this box here. So they talked about the need for prevention of recurrent and new cancers, but also to try and prevent the late effects that we might anticipate. We need to think about surveillance, and not just for cancer spread and recurrence, the possibility of another cancer, but also assessment for the medical and psychosocial late effects. We need to think about intervention for the consequences of cancer and its treatment, including medical problems listed here such as lymphedema and sexual dysfunction, symptoms such as pain and fatigue, psychological distress that we know can be very common in both survivors but also in carers and family members. And we need to also pay attention to issues such as employment, insurance, and disability. And we need to make sure that care is well coordinated between oncology providers, primary care providers, and others to ensure that survivors' needs are assessed and met. They talked about 10 recommendations. The first was about raising awareness of the issues for survivors and the importance of this post-treatment survivorship phase. The second was around survivorship care plans. So people should be given information about their cancer diagnosis, the treatments they had, and the sorts of issues that they might experience, as well as strategies to remain well and what people can do for themselves to manage the post-treatment phase. There was a need to develop and to use evidence-based guidelines, as well as to develop and use quality measures, to explore new models of care, to embed survivorship considerations in cancer control plans, a need for education for health professionals, to ensure that survivors are supported to return to work and not discriminated against, that they need access to high-quality survivorship care, and the need for broad research around survivorship. In Australia, the Clinical Oncology Society of Australia developed a model of survivorship care in 2016, and this is available on the COSA website, and it describes critical components of ideal survivorship care. This illustration is included in your pack. I won't go through it in detail, but it does talk about the need for needs assessment, and toward the end of treatment to consider the need for rehabilitation. People should be given a treatment summary and a care plan, and care should be based on the needs that people have as well as anticipated risks. People who have low-level need and have low risk of developing recurrence and other complications, many of these people may be able to pursue self-management with support as long as they're having their recommended testing. Other people might need more professionally led care, which could be community-based or with oncology specialists. So it's basically a notion of personalised pathways of care that are based on people's needs and anticipated risks. We also need to ensure that if people have a new problem, that they have timely re-access to care. So this is described in the COSA model, which you can review online. We've also described this in a position statement published in the Australian Journal of General Practice at the end of 2019. I'll just describe a few elements of this. So we say that healthcare teams should implement a systematic approach to enhance coordinated and integrated care. Survivorship care should support wellness and healthy lifestyle with primary and secondary prevention, while preventing and managing treatment-related symptoms, late effects and comorbidities, as well as cancer surveillance. I mentioned stratified pathways of care. We mentioned too that at the transition to follow-up, we need to ensure that people have a treatment summary and a care plan. And survivors require equitable access to services in a timely manner while minimising unnecessary use of healthcare services and resources, recognising that we have limited healthcare resources. There are other guiding frameworks. Throughout Australia, we have the optimal care pathways, and for most cancer types. And at step 5, we consider care after initial treatment and recovery. And again, highlighted in this, the importance of a treatment summary, a care plan, and good coordination between oncology providers and primary care. Cancer Australia, the peak national government agency, has also articulated principles of cancer survivorship, which are also available in your pack, but also on the Cancer Australia website. In Victoria, we are required by law to have a cancer plan, and our current cancer plan again emphasises the survivorship phase, and the Victorian government has supported the Victorian Cancer Survivorship Program for over 10 years, which has explored a number of models to better support cancer survivors. Turning now to the Australian Cancer Survivorship Centre, the ACSC is based at Peter Mac in Parkville. We've had funding from the Victorian government and from Peter Mac since we began, and philanthropy through the bulk of that time. We had our official launch in 2010, and our funding supports just a small staff. We have a dual focus because of our funding, the dual focus on both Peter Mac and the whole state. We don't provide direct clinical services, and we're more about trying to improve service delivery rather than research. We have 3 broad areas of focus around information and support for survivors, education and training for health professionals, and providing leadership and guidance around cancer survivorship. We see our role is primarily about supporting and enabling others, and we work with a broad range of health professionals, consumers, government and non-government organisations. And what we're trying to do is to achieve optimal outcomes for survivors and carers. We have a strategic plan available on our website, and again, our vision is to optimise the health and wellbeing of survivors and carers. We've got 6 broad areas of focus, and again, you might like to look at that on our website. Just briefly, some illustrations of some of our work. In terms of providing information and support for survivors, we've developed guidance for consumers about many prevalent survivor groups. We've also developed survivor stories, and we've developed information in a range of other languages. We did this in partnership with Cancer Council. The resources are branded by Cancer Council and promoted and distributed nationally. We've also developed information as audio resources and video resources in English and in other languages. And you'll see also we've developed resources for particular groups and as an illustration here for young people. We've also developed a common survivorship issues directory, and this at this stage has 10 common issues reported by survivors. So you'll see issues such as fatigue, fear of cancer recurrence or progression, issues with returning to work and study, sleep issues, etc. Just as an example, here on anxiety and depression, we've got a list of services at Peter Mac. We've also got links to guidance documents, information for survivors and families, and for some areas, additional resources and projects. In terms of education and training for health professionals, again, we've got information about particular cancer types. Here, in this example, survivors of diffuse large B-cell lymphoma. And we've also developed resources that are specific to particular professional groups, and this is an example of a resource for general practice. We've developed follow-up guidelines for a number of cancer types. We've also developed toolkits on some issues, for example, needs assessment, survivorship care plans, and we've published on our work as an example, the impact of survivorship care planning on patients, GPs and hospital staff. We've also developed online training and currently have resources that are being hosted by EviQ Education, which we're currently refreshing. And we've also embedded survivorship considerations in a number of the other EviQ modules. In terms of leadership and guidance, ACSC contributes to state, national and international guidelines and to policy documents. We have membership on the executive of the COSA Survivorship Group, as well as membership of international groups, including the American Society of Clinical Oncology Cancer Survivorship Committee. ACSC also convenes a survivorship community of practice. We have a forum for clinical champions and also a regular research forum as well. We've co-convened a biannual Victorian Cancer Survivorship Conference, most recently hosted in March 2020. And we provide support to quite a range of groups in terms of models of care and research projects. So I'll leave it there and leave you with some contact details. The general email address to contact us at ACSC, the ACSC website, which is petermac.org/cancer survivorship. We've got another website, which is a survivorship care plan generator at mycareplan.org.au. I mentioned the Common Survivorship Issues Directory, which is petermac.org/servedirect. And you might like to follow us on Twitter and LinkedIn. Thanks very much.
I'm sure we all found Professor Michael Jefford's presentation helpful in developing our understanding of cancer survivorship care. Next, we will hear from Professor John Emery, who is a Hermann Professor of Primary Care Cancer Research at the University of Melbourne. Professor Emery is also a leader of primary care research and education at the Victorian Comprehensive Cancer Centre.
Hello, my name is John Emery, and it's a pleasure to be with you as part of this UCCC 2020 Information Night. It's a great shame that we can't all be together physically for this evening, but I hope to be able to provide you during this presentation an overview around certain aspects around new models of cancer survivorship care. The background to why we need to start thinking about delivering new models of cancer survivorship care is partly shown on this slide. Over the next 15 years, it's expected that there will be an increase in incidence of cancers in Victoria of 43%. This is driven partly by population growth, but also population aging. And so an increasing number of patients will be diagnosed with cancer. Fortunately, the majority of these people will have good outcomes. Nearly 70% of patients with cancer will be effectively treated and live at least 5 years beyond their diagnosis. The image that I'm projecting is from the Victorian Cancer Registry, estimates of the number of cancer survivors that will be in Australia by 2040. So you can see there will be very large numbers of prostate cancer, breast cancer and colorectal cancer survivors, and also large numbers of people living for many years after a diagnosis of melanoma, and to a lesser extent other cancers as demonstrated. So these large numbers of cancer survivors are all going to require ongoing care and management, both for the acute effects of their treatment and the longer term consequences of their cancer diagnosis. This is the Victorian Comprehensive Cancer Centre, and where many patients are continued to be followed up for many years after their cancer treatment. Our current models of survivorship care are very hospital-centric, where patients are brought back on a regular basis over many years of time, and their care is not really transferred across to primary care at all. The difficulty is, as we have growing numbers of cancer survivors, we can't keep building new hospitals like this to deal with the large numbers of new cases, and we need to be thinking about alternative models for providing ongoing care for this growing number of cancer survivors. This is taken from a key report from the Institute of Medicine in the US, which describes the 4 core components of good survivorship care. This focuses on the prevention of recurrent and new cancers and of late effects, the surveillance of cancer spread and recurrence, and the assessment of medical, physical and psychosocial consequences of their treatment, intervention for the consequences of their treatment, and coordination between specialist and primary care to ensure that all the healthcare needs of survivors are met. The problem that we have at the moment is most survivorship care focuses on just one aspect of this: surveillance of cancer spread and detection of recurrence, and to a lesser extent, the assessment of medical and physical consequences of treatment. This is the Lancet Oncology commissioned report around the expanding role of primary care in cancer control that was published in 2015. There's a large section that covers issues around cancer survivorship in this report, and these are just 3 of the key findings from this. The first is a recommendation that we need a greater clarity around the role of primary care in survivorship care. The second reflects on the evidence that already existed that showed that primary care or shared care models of follow-up are just as effective as hospital-led follow-up, at least for breast and colon cancer, as the evidence stood back in 2015. And third recommendation was that new models of survivorship care should be applying the principles that are well established for the management of other chronic diseases. So this diagram presents what's called the chronic care model. It's a model developed by Wagner over 20 years ago and has been well applied for the management of other chronic conditions such as diabetes and cardiovascular disease. And it reflects the importance of organising healthcare systems and redesigning the healthcare system so that patients receive the care in certain different components of the healthcare system, in hospital care, in primary care, according to their needs, with good clinical information systems that support and integrate that care between hospital settings and primary care systems, and that practitioners receive decision support to ensure that best practice is implemented, so that you have a prepared and proactive practice team delivering chronic disease care across the healthcare system in both primary care and hospital settings. The other side of this reflects the importance of supporting patients in the community through resources and policies that allow them to increasingly self-manage several components of their chronic condition. so that you have informed, activated patients. This model has been shown to be very effective in the management of a number of chronic conditions such as diabetes, arthritis, and heart failure. And the recommendations are that we should increasingly start to think of cancer as a chronic condition, and that we should be applying the same principles of chronic care model to the way we think about cancer survivorship care. This is another important model produced by the Clinical Oncology Society of Australia, or COSA, a couple of years ago, and it reflects a model of wellness in cancer survivorship that commences from right from the point of diagnosis through to considering different models of follow-up care. One of the key aspects of this model is the issue around risk stratification. So stratifying cancer survivors at the end of treatment to think about their current needs, the complexity of their treatment, the complexity of the consequences of that treatment, and how that can then be used to determine what model of follow-up could be applied. So those with low-risk disease, who haven't experienced significant consequences of their treatment, have low risk of recurrence, could actually be predominantly followed up through self-management with only, as required, involvement of the healthcare system. Those at moderate risk are professionally led follow-up, but potentially involving combinations of primary care-led follow-up and specialist-led follow-up. And only those who are at high risk of recurrence or who have other high complex needs are predominantly followed up in the specialist care setting. So again, just returning to the way we think about different models of survivorship care. So this is our predominant model at the moment, which is cancer centre-led, bringing patients back on a regular basis for follow-up visits, where often the focus is on detection of recurrence and management of the physical consequences of their treatment. An alternative model that has been trialled particularly in breast cancer and in a number of trials in the UK and in Canada is where you actually hand over the follow-up care entirely to general practice and the primary care team, and that hospitals essentially discharge patients after a period of time from routine follow-up to be managed entirely by the GP and the other members of the primary care team. The third model is one around shared care, where certain aspects of follow-up and survivorship care are managed by the hospital setting and the specialist setting, and other components are managed by general practice, and where there's a much more integrated model of care with good communication between general practice and the hospital specialists, and with different components of care provided at different time points in an ongoing basis. And so the model of shared survivorship care is one where the patient is partly self-managing, where they're having routine follow-up visits, predominantly delivered in primary care, but sometimes with additional specialist visits as well, where if there are causes for concern, then there is rapid access back to the specialist care on an as-required basis as well. So as I said, until recently, the majority of evidence around alternative models of primary care-based follow-up for survivors has been focused on breast and to a lesser extent on colon cancer. The ProCare trial was the first trial to test a model of shared care for men with low to moderate risk prostate cancer. It was a trial that Michael Jefford and myself and Penny Schofield and a large multidisciplinary team ran in a number of centres in Victoria and Western Australia. And this is essentially the basis for the model of care. So our current model of usual follow-up care is that a man completes his treatment and is then followed up initially at 6 weeks and then on a 3-monthly basis for the first 12 months. And they would have at each of those visits a PSA test and a review of their current symptoms. The trial shared care model in ProCare was one that introduced a visit for 2 weeks with a GP. Often, one of the challenges for general practice is that patients will have lost touch with their GP during their cancer treatment. And the idea was of having an early planned visit with their GP shortly after their treatment had ended, and an opportunity to catch up with their GP to discuss their current concerns and see how they were getting on, and also to review their survivorship care plan. And then you'll see that within the ProCare shared care model, the 6 and 9 month hospital visits were replaced with general practice visits. So this was a more integrated sharing of the follow-up visits, sharing of the PSA testing, and review of symptoms. One of the innovative aspects of the ProCare model, though, was also to introduce the use of the distress thermometer, which is a screening tool for psychosocial distress, but also it was a checklist of items to identify unmet both physical, psychological, and social needs. So that the patient was asked to identify the 3 things that they actually wanted to discuss with their GP at that visit, and hand that distress thermometer and the unmet needs checklist to guide the discussion with their patient in an attempt to reduce some of the unmet needs that we know that the current model of prostate cancer follow-up leads to. I recommend that you look at the details of the trial design and the trial results from those 2 papers that I showed in a previous slide, but these are the main findings. The most important ones are that quality of life, both in terms of physical side effects of treatment and psychological outcomes, were no different between the 2 arms. That men who were exposed to the shared care model much preferred this to the previous hospital-based models of follow-up. And that on average, this was a slightly cheaper model. So per man, over a 12-month period, ProCare from a health system point of view was $323 cheaper than current models of hospital-based care, predominantly because hospital care hospital outpatient clinics are more expensive than GP-based clinics. We've gone on, again, with Michael Jefford leading the SCORE trial to apply the principles of the ProCare trial into a trial of a model of shared care for colorectal cancer survivors, which is currently being conducted in a number of sites within Victoria. But I think it's important to recognise that shared care is increasingly being promoted at a national policy level as a good model of survivorship care for a number of cancers. So on the left is a shared care plan for women with early breast cancer that has been created by Cancer Australia, which is the federal cancer agency. And on the right is a shared follow-up care model for women with low-risk endometrial cancer, and a guide for general practitioners who get involved in the delivery of shared care for women.
You reckon I would have thought it?
Cancer. Endometrial cancer is a good example, again, of a condition where women will often have a number of comorbidities, such as hypertension and diabetes, that we know are risk factors for endometrial cancer, and where the management of those risk factors is a very important aspect of the broader holistic care of women with endometrial cancer. So I think increasingly we will see a policy push to develop more shared care models for cancer survivorship. The ProCare trial findings are already being applied in a number of sites in Victoria. And again, so that we are gradually seeing a shift to the implementation of these models of shared care for a number of different cancers within Victoria and nationally. However, there are a number of important areas of uncertainty that I think you need to be aware of and should consider when you're developing your proposals. The first is this whole issue of how to upskill GPs and practice nurses to deliver cancer survivorship care. Now, traditionally, there have been models that have assumed that GPs need to attend seminars or other forms of face-to-face training before they are in a position to take on this new role in supporting cancer survivors in general practice. What I'm showing you on the screen is a mass open online course that was developed by a group of us at the Victorian Comprehensive Cancer Centre, which was essentially a modular course that involved a number of hours of online education around a broad range of delivering cancer survivorship, designed specifically with the educational needs of primary care practitioners. And this has had over 2,000 people enrolled on this programme. One of the challenges, though, of course, there are 30,000 odd GPs in Australia, and the question is, how do we actually reach this large number of GPs who may not necessarily recognise their educational needs in cancer survivorship? An average GP will have perhaps 6 or 7 new patients diagnosed with cancer each year, and they'll have maybe 30 to 40 cancer survivors on their, that they will be seeing on a regular basis. But they may not recognise that this is an area that they need to be investing their educational time in. And so it can be challenging using these traditional models of upskilling. The alternative view is actually that this is all about ensuring that GPs have the information that they require when that cancer survivor comes to see them. And so this is about delivery of just-in-time information. So rather than assuming that GPs need to attend educational forums, this is around good clinical information, good communication between hospital settings and general practice, and essentially using models such as a shared care plan to provide decision support and information that GPs require when a cancer survivor comes to see them for a follow-up visit. So again, this is taken from the Cancer Australia Breast Cancer Share Care Plan, and is just an example of how you can quite simply summarise what are the core aspects of care that are required in that follow-up visit, and provide just-in-time information that a GP needs to deliver good survivorship care. And I think that's possibly a more sustainable model than expecting GPs to have to attend either online or face-to-face seminars before they can take on this role. And there's evidence that has been from qualitative interviews that the Australian Cancer Survivorship Centre have conducted that suggests that this is how GPs view their requirements more than an expectation that they require attendance at various educational events before they can take on this new role. The other issue I wanted to bring up is the role of telehealth in new models of cancer survivorship. So during the COVID epidemic, cancer centres have had to shift quite quickly to providing alternative models of cancer follow-up, and many have taken on a model of telehealth to provide an alternative model of follow-up so that cancer survivors didn't need to come back into the cancer centre for their follow-up visits. Now, many of those telehealth models have continued to bypass general practice, and where those telehealth consultations have occurred in the patient's home and directly with a clinician at the cancer centre. But I think this is missing an opportunity to integrate general practice better. This is a photo taken actually of a practice nurse in general practice with the patient who's a cancer survivor having a telehealth consultation with the cancer centre. And so we should be thinking about how we can continue to build on what's been learned of in telehealth and models of follow-up that cancer centres have started to adopt, but how we can adapt those to better integrate general practice and involve the general practice team in those telehealth follow-up visits. And finally, I wanted to bring up the important issue around patient preferences for follow-up and how do we account for those. From our experience in conducting trials like in ProCare and SCORE, we know that many patients are very open to thinking about new models of survivorship care, and that we've been able to recruit a large proportion of patients into these trials who are very open to the greater involvement of their general practitioner in shared care models of cancer survivorship. But at the same time, there are some patients who are very resistant and wish very strongly to continue to have their cancer follow-up conducted entirely by their cancer specialist, who they've often developed a very strong and trusting relationship with, and who they feel can provide them with the best care. So we need to think about how we build trust in these alternative models, how we allow patients to still maintain a relationship with their specialist, and that's where shared care models, I think, have an advantage over GP-led models, but that also that the specialist system allows patients to develop trust in their GP's role in these shared care models. So I think it's another challenge about how do we help build that trust, how do we ensure that patients' preferences are recognised and respected, but at the same time, how we ensure that the capacity within the hospital system, particularly to see newly diagnosed patients, is still possible while continuing to deliver survivorship care for this growing number of people living long-term with and beyond cancer. And so on that note, I'd just like to wish you good luck with your proposals, and I look forward to any questions that you may post around this talk. Thank you.
We extend our thanks to Professor Emery for presenting his thoughts on models of cancer survivorship care. To give you a different perspective of cancer survivorship care, we have Michelle McIntosh.
Hello, my name is John Emery. It's a pleasure to be with you as part of this
who is an accredited exercise physiologist
UCCC
at Golden Valley Health, where she is a facilitator of the Cancer Wellness and Exercise Program.
Hello everyone, my name's Michelle McIntosh, and today I'll be doing a talk on cancer survivorship in a regional setting for the University Cancer Case competition. So just the points that I'll cover off today. So I'll be discussing my work as an exercise physiologist with cancer survivors. Also cancer survivorship in a rural and remote area and the unique issues that present themselves with this cohort. And lastly, I'll be discussing our cancer wellness and exercise program that we run at Golden Valley Health. So just a little bit of background on myself. So I'm an accredited exercise physiologist and I work in the Community Rehab Centre at Golden Valley Health, which is located in Shepparton, Victoria. And hello everyone, in a regional setting for the University Cancer Case competition. So just the points that I'll cover off today. So I'll be discussing my work as an exercise physiologist with cancer survivors. Also cancer survivorship in a rural and remote area and the unique issues that present themselves with this cohort. And lastly, I'll be discussing our cancer wellness and exercise program that we run at Golden Valley Health. So just a little bit of background on myself. So I'm an accredited exercise physiologist and I work in the Community Rehab Centre at Golden Valley Health, which is located in Shepparton, Victoria. And this is my 5th year working at the hospital. I work across a varied range of chronic diseases, cancer being one of the main conditions I treat and programs that I'm involved in. I commenced working with patients with cancer around about 2017. And that was due to a few different reasons. It was my own interest, so I thought cancer was a fairly wasn't an area that many exercise physiologists have been working in at the time, but also there was lots of evolving evidence and research around exercise and cancer being released. And another really big reason why I went into it was there was a service gap in our centre. In that there wasn't any current cancer or once they'd finished their cancer treatments. So there was definitely some room for improvement. In terms of my other experiences with cancer, at the time I hadn't done a lot of work in it, so I did go on and complete some further training with Cancer Council Victoria, as well as the Peter MacCallum Cancer Centre in cancer care and exercise and oncology, just to gain a further understanding of the different cancer streams and all the precautions, and just a greater understanding of how to manage and treat patients with cancer. I find the area of cancer and exercise, as well as cancer survivorship, a very challenging but rewarding area of my role to work in. It presents itself with lots of unique issues and lots of things we need to think of as exercise physiologists to make sure they're giving the patient a safe and effective exercise program, but it always results in such a rewarding experience with the patient. So it's a really great area to be working in. So just a little bit on cancer survivorship and why I enjoy working in this area. So cancer survivorship can be described as the process of living with, through and beyond cancer. So meaning it begins at diagnosis and continues through the patient's treatment cycles and after. It really starts back when they have that initial diagnosis. There is research that shows that there are more than 1 million Australians living with and beyond their cancer diagnosis. And with newer research, earlier detection rates due to new screening tools and continual improvements in treatments, patients are living and surviving a lot longer. However, when patients finish their treatment, they can often feel confused, alone, anxious, and face many challenges returning to a sense of normality. These can include emotional, physical, social, and practical challenges. Side effects from treatment can often cause debilitating issues for patients and last many years after their treatment finishes. So we're having more of a discussion now about the unique issues that patients are presented with when they are from a regional or rural area. So some of the main issues I've found from my experience are the access to services. So it can be quite limited and difficult for patients due to their residential location. So they might often having to travel 30 to 60 to 90 minutes or more to get to the hospital for treatment or to see myself, and often that extends their travel time. So it might be a whole day sometimes that they need to commit to. Often financial states that can affect if their ability to actually get to the program, and the lack of public transport in regional and rural areas is quite prominent. So there's often not a lot of public transport available. So if patients are unable to drive themselves, they're needing to rely on friends or family or other community transport options to get there. And there are often criteria for being able to access those services as well. So it can create quite a big problem just even getting to the program. The lack of resources and staff to deliver services is also quite a big issue in regional areas. So we often have to rely on other health services around us to support us in being able to deliver these type of programs, or just a single service. So we often need to kind of link in with other health services to share resources and even staffing, which links into my next point about telehealth. So we are quite fortunate to be able to use telehealth where we are. However, this comes with its own set of issues in terms of technical issues, issues with connectivity, and it also heavily relies on the user being knowledgeable in how to use telehealth, which, you know, we don't normally get a lot of education on it prior to using telehealth with patients. So telehealth has been such a great form of being able to connect with our patients and treat our patients, but it can be quite a big issue in telehealth, especially if patients aren't able to use it themselves, if they don't have data, they don't have internet, or the right setup at home to be able to use it. Another point I'd like to make is that patients often travel for their clinical treatments, their chemotherapy, or going to have surgery, or even their radiation as well. So often once they've finished that side of things, they just sometimes want to be finished with all their appointments, which is very understandable. So that at times they don't often want to come back into the hospital to see us for exercise therapy or for any other follow-up therapy, which creates in them being able to access that service. So often, you know, patients, while they might have had a complex issue arise, you know, needing to have been admitted into hospital, and that can often create a bit of an association with the hospital, not really wanting to come back into that environment. So you can see there's lots of issues that patients can face just by living in these areas. Looking more now at how we've overcome some of these issues. So GV Health is located in Shepparton in Victoria. And lucky we are a central hospital for a lot of surrounding smaller towns, and through this we've been able to reach a lot of patients that are in rural and remote and isolated areas to provide the program to and to limit travel. So that's been a big win for us. Telehealth has been used a lot to provide education to both our patients in our program, and also to provide support to the smaller hub programs that have started up in more recent times, and they're in smaller towns. So a big advantage of using telehealth during the last few months with COVID has been that we've been able to continue delivering our program to patients, just delivering the education component. However, on the other hand, one of the disadvantages we've had is it's prevented us in gathering pre and post outcome data, because we haven't had that face-to-face contact with patients. So telehealth has definitely been a big thing that we've been able to use in delivering our service, but it has come with its advantages and smaller disadvantages. With radiation treatment, we are quite lucky that it's now offered locally at Genesis Care in Shepparton. This has reduced a lot of the travel time for patients that they previously had to travel 2 or 3 hours to attend radiation treatment, and conversely had a more positive impact on their day-to-day life and reducing fatigue that's often associated with those longer periods of travel. We'll also acknowledge the role of our oncology department in supporting our program, both with referrals, promotion of the program to patients that are coming through, and their ongoing involvement. So they've been a really great support. So I'll move on to talking about our cancer wellness and exercise program now. So this was previously known as the Wellness and Life After Cancer program. We renamed the program last year due to feedback from patients regarding the afterword, suggesting that they no longer have cancer, which we know is not the case. It's often a long-term illness. So the Cancer Wellness and Exercise program is an 8-week exercise and education supportive care program for patients who have completed primary treatments. So this includes their surgeries, their chemotherapy and radiation. We've been running the program since 2017, and it was developed by Cancer Council Victoria and then implemented into the regional areas in Victoria in 2017. So we've been running it consistently since then with some great success out of the program. The program is delivered by qualified health professionals, including exercise physiologists, nurses, social workers, allied health assistants, dietitians, occupational therapists and many other clinicians. So it does have a very big multidisciplinary approach to it. And that's because cancer is very multifaceted. It's never just relating to one clinician. We know it affects a lot of aspects of a person's health. So the main aims of this program were to help patients connect with others going through similar experiences. It was to help them manage treatment side effects. And these could include fatigue, poor balance and coordination, bone pain or weakness, lymphedema, and more specifically deconditioning, which is quite common when a patient undergoes their primary cancer treatment and they may not be able to remain as active as they were previously. So there are lots of different side effects, but those are just a few main ones that we generally see improvements in. The program also aims to teach patients how to cope with their life now after going through a cancer diagnosis, and helping them to find a new normal, which is a new term, but often patients say that it's about finding a new normal. They know that they may not get back to where they were previously, but it might be a different way of living their life. Another big aim of the program is to help patients access and just understand what the local services are and how to use them if they need. So for the purpose of this presentation, I had a look at program data from July to December of 2019, so for a 6-month period, just to have a snapshot of how many programs we completed and our referrals. So in that time, we had 3 programs completed with 26 referrals in program and 20 patients completing a cancer wellness program. The outcome measures that we chose to measure pre and post program were based on both questionnaires to gain some subjective data on quality of life and fatigue, and we also took some physical capacity measures. So the 2 questionnaires were the FACET-F and the FACT-G scale. The FACET-F fatigue scale stands for the Functional Assessment of Chronic Illness Therapy, and this is a 13-item questionnaire asking patients to rate their fatigue over the past 7 days and how it affects different activities. The FACT-G scale is a patient-reported outcome measure used to assess health-related quality of life in patients undergoing cancer therapy, and that stands for the Functional Assessment of Cancer Therapy General. And FACT-G has 4 categories that are assessed, so it includes the patient's physical well-being, their social and family well-being, emotional well-being, and functional well-being. In terms of the physical measures, we chose the 6-minute walk test to assess aerobic capacity, as this was easy to administer and very convenient for the patient to complete. For lower limb endurance, we used the 30-second sit-to-stand test, and for balance, we chose the tandem and single leg stance measures. So just having a look at the findings from that data collection. So the pre and post measures in the majority of patients demonstrated improvements in self-reported fatigue levels and quality of life across all 4 domains. And I'll just go through some of the feedback that patients reported on. So patients from the program helped them to regain self-confidence. They felt more energised. They also found fellowship, and they didn't feel so alone. It also helped them to normalise the side effects that they were experiencing, and they just felt a lot more connected to others and like they weren't kind of completing this next phase of their recovery by themselves. They found like they had a lot more support in going through that. We also found improvements in lower limb endurance, and this was through the sit-to-stand test, which is transferable across to functional movements. So sitting and standing out of a chair, getting out of the car, getting off the toilets, all really common movements that are completed throughout a patient's day. But again, they often find them quite difficult. And that's not for every patient, but across the board, we found that was a big improvement. We found that aerobic capacity was greatly increased over the 8 weeks, and this relates to their walking tolerance. So they were able to walk for a longer period without feeling so fatigued or without having symptoms of pain or shortness of breath. And we also found single and tandem balance scores improved over the 8 weeks. So these two tests are quite important for a patient's postural stability, their gait control, and when ambulating up and down stairs. So that comes to the end of the presentation. These are some references if you wish to have a look. And I'd just like to say thank you for listening to my presentation. I hope you've gained some insight and a better understanding of cancer survivorship, especially among regional and rural patients. Thank you.
Thank you, Michelle. Lastly, we have Stephanie Lee, a member of the winning team of the Emory International Global Health Case Competition and an MD candidate at the University of Melbourne, to give you some tips on how to approach case competitions.
Hello, my name is Stephanie, and it's a pleasure to be with you as part of the UCCC Info Night. I'm currently a medical student, and I've been asked to give some advice tonight because I've had a little bit of experience with case competitions, and I find them a really enriching experience. I hope that will be the case for those of you who choose to participate as well. So tonight, I've been asked to give you an overview of the case approach, suggest some considerations for developing your solution, and offer some advice for your presentation. Before I start though, a brief disclaimer. I'm not a case competition champion by any means, and not all of the advice I give will be useful to you. It's certainly not a prescriptive formula for winning. I think it's incredibly important to find a way to maintain your integrity and style in this process, and what I hope to offer is a starting point if you get stuck. I'd like to first start by addressing the case approach. If you look online, you'll find loads of resources about how to attack a case. And I'll be talking through some of the methods I find really useful for structuring your approach shortly. But the first step to tackling a case starts well before you even read that case file. And that's with choosing your team. When I participated in the University of Melbourne and Emory Global Health case competitions, they both set a diversity quota. That's because some of the biggest learnings from case competitions come not from the interesting and impactful cases, but from the environment you cultivate. That environment is an opportunity for you to meet and learn from others and collaborate in a multidisciplinary way that more closely resembles a real-world environment. When you have a team of different people from different backgrounds, be that academic or socioeconomic or ethnic, each of them will see the problem from a slightly different perspective. The interaction of all these perspectives produces something that is different and broader than what any individual could come up with. Your solution space, or your realm of possibilities, is much wider, and it makes it much more likely that you as a team will find an approach that's creative and innovative and all the other buzzwords. You might have also identified the obvious caveat that different perspectives sometimes produce conflict. Everyone's going to want to approach the problem a different way, and you need to be prepared to respect each other enough to compromise and flex so that the approach is representative of all of you, not just you. That means that once the team has made a decision, you're all on board with it 100%, even if it wasn't your idea. So moving on to some problem-solving approaches. Some of the words you might have heard thrown around out there are the double diamonds, or design thinking, or McKinsey problem-solving method. All of these are in some way a recipe for problem-solving, and there are many, many more out there. What you need to be able to do is tweak these recipes to suit yourself and your team. I'm going to go through approximately the version I tend to use. It's the version that makes the most sense to me, and hopefully it makes some semblance of sense to you. But even then, I don't necessarily go through these steps in order, or even all the steps, all of the time. I've broken up the steps into 3 parts that represent your relative depth of knowledge at each step of the process. So starting with a blank slate, a whole new world, if you will. When I first approach a case, I like to go in assuming nothing with an open mind. But knowing nothing isn't the same thing. If you're doing a case on something completely foreign, something completely unfamiliar, it can be really hard to get going. I find it useful to do a little bit of preliminary reading, not necessarily about the case, but enough to familiarise yourself with the industry and the terms used so that you're not Googling every second word in the brief. Throughout this presentation, I've just highlighted some of the tools I like on the bottom right-hand side. In this case, you're looking for broad knowledge, so either talking to an expert or just browsing a few Wikipedia pages can be enough of an introduction. Then, a few things to keep in mind when defining the problem that I've shoehorned into a mnemonic. I know that a problem is given to you in your case briefing, but that's not necessarily the problem that you have to solve. I think this is one of the most important steps because it sets your compass for the rest of the case. It might seem counterintuitive to apply the right constraints and be specific at this stage, but I find that this actually encourages more creativity down the track and ensures that you stay on track. Set smart goals that make sense given your resources and make sure that you stick to your brief. Do what's asked of you and don't deviate from that. At least not too much. The end product of this section should be a how or why question that's specific in terms of time frame, audience, resources that you can then solve. Almost every problem-solving manual has some sort of tree. This is to help you break down the problem into digestible components. How you actually construct this tree is completely up to you, but if you're not sure where to start, look into theoretical frameworks that help you understand the drivers of your problem. So down the bottom, I've put the 7S framework, which is one from McKinsey. If your problem is a how problem, you should be similarly asking how questions to establish your tree, and same thing if it's a why problem. Whatever you call this tree, whether you call it an issue or a hypothesis or a logic tree, there are loads of resources online telling you how to make this tree and how to make it work for you. I also found untools.co a really useful resource. If you don't necessarily want to make the traditional issue tree, there are lots of other ways to approach the problem that don't focus on a messy approach like the issue tree does. After you've got a handle on your problem, you should be much better placed to try and tackle it. So most of the problems that you're presented with are relatively complex. There won't be a clear-cut solution and there'll be parts that you can't or don't address. It's therefore important to prioritise your issues rather than trying to solve everything. Branches of your tree don't have equal weight just because they've been drawn that way. The Pareto principle, or the 80-20 rule, applies to most complex problems, but it can mean that you put more emphasis on low probability, high impact issues, or vice versa. That's completely up to you. Because you want maximum efficiency gains, you probably want to look for opportunities to compound impact, like feedback loops. Useful tools at this stage are things like the Eisenhower matrix, which help you make decisions about what to prioritise, as well as just doing a basic SWOT analysis. There's always going to be a stage where you need to sit down and do the work. Once you've figured out how to allocate your time and resources, you need to sit down and do the analysis. That can mean number crunching or more in-depth research into problems to prove yourself right or wrong. There are very few new problems out there, so it can be useful to see how others, maybe in other industries, have tackled a similar problem. If you're not on board with Excel at the moment, not a problem, but I would definitely learn to use something like a pivot table in particular for analysing your data. It's also quite useful to look at existing industry frameworks, not only from the industry that you're looking at specifically, but from others that have similar goals or may have similar problems, to see whether any of those fit. Now you should finally be at a stage where you're actually ready to solve this. You can see the light at the end of the tunnel. Finding an intervention, ideating, can be the easiest or hardest part. Everybody solves problems in different ways. Some people brainstorm freely, some people prefer to structure their thinking. One of the most important things and most valuable things that you bring to your case is a new perspective and a disregard for the impossible or the status quo. But I find that solid boundaries and limits can actually produce more creative thinking because you've got more to work around. Straight lines aren't super creative, but if you've got an interesting curve because you've had to work around some corners, that's much more interesting. In terms of tools to help you with your thinking, if you liked the issue tree, a solution tree might be the solution for you. So you start with your hypothesis and then work down the tree to multiple solutions that could solve the problem in different ways. If you prefer more of an unconstrained approach, 100 ideas where you literally take post-its and put 100 ideas on a wall or a whiteboard might suit you better. And if you're more of an in-the-box thinker, there's a process called systematic inventive thinking, which encourages you to use your constraints and really think about how that changes your problem. So once you have a couple of solutions, it's time to pick your favourites and prune them back. Add in your time and budgetary constraints if you haven't already, and look for solutions that remain feasible, acceptable, and impactful. If your final goal is 10 steps away, it's enough to take one step towards it in your solution. You don't need to fix everything. In fact, it can be very inefficient to do so, and the shotgun approach is honestly lazy because it means you haven't prioritised your issues properly. At this stage, something like a decision matrix, evaluating each of your solutions based on feasibility, acceptability, and impact can be useful, as can be talking to some experts about what they think might work or might fail. The final step is to synthesize your problem. All those whiteboards full of work and multiple Google Docs might be great for you, but the audience and judges won't see that. Synthesize the problem so that your solution seems obvious. Take all the effort and make your conclusion look effortless, like it's the only right path. That's it. Easy. Unfortunately, I wasn't lying when I said I don't usually follow this recipe, at least not exactly. One of the most important parts of problem solving is to keep iterating. So while this method might be good for a first pass, you'll need to jump between the steps as you keep going and keep cycling until you're satisfied. Once you've got a solution that you're happy with, you need to bring it to life. Prove that you've thought about it deeply, or at least give the impression of having done so, about what it takes to make the solution logistically possible. Every part of your solution should support the idea that this will work well in the time that we have and come in under budget. And if it doesn't, we know why and we can fix it. So starting from the top, your program logic is your inputs, outputs, and outcomes, the structure that you provide your intervention. This reassures your audience that your intervention makes sense and that you're actually doing something which will have some sort of outcome. Your impact evaluation is how you set yourself apart from other interventions. Do you have a better return on investment? How much change can you make? And in what specific domains can you make it that other people aren't doing? Your timeline should include everything from preparations to rollout to evaluation, and should also make clear any dependencies along the way. Be realistic about how long things take and make sure that you don't just magic up infrastructure or human resources out of nowhere. People take time to train, buildings take time to build. I find it useful in budgeting to separate out capital and operating expenses, as well as the main areas where the funding will be spent. And ideally, you want to plan for longevity and sustainability. Make sure that your numbers make sense, because they're one of the most common questions, and be prepared to defend them if they seem a little bit unrealistic. Risk assessment, I think of as a way to almost anticipate questions and defend key assumptions that you've made before they're asked. It demonstrates that you're aware of the limitations of your intervention and have thought critically about how to resolve them. Evaluation is a critical component of both successful programs and successful failures. Make sure you have regular evaluation of your program and consider having a contingency plan if things don't go to plan. And finally, iteration. Iteration isn't something you necessarily do on its own, but it should be something you build into your program deployment, ideally in a staged rollout, so that you have an opportunity to fix any issues that arise before the entire program is affected. And that's it. There's your proof that your solution isn't just words on paper. It could come to life, and it makes sense for it to. The last thing to think about is putting this all in a neat package and wrapping it up in a bow, the presentation. I prefer not to do my presentations last. Instead, I ghost it towards the beginning and fill in the blanks as I go. That way, I only make the graphs that I need and only do what's important, because time is limited and you can't become a subject matter expert in a matter of weeks. You need to focus your research and focus your data analysis. Having a deck from the beginning also means that you can amend things along the way, and critiques of everything from structure to wording to aesthetics only improve the deck as you go. When you go to present, you want to tell your audience a story. Take them on a journey with you in a way that makes your path seem like the only logical one. I find the SCQA framework particularly helpful in framing a deck, but make sure that you're spending the majority of the time on the answer because that's what your audience is really interested in. They already know the situation, they're in it. They've come up with a complication for you. The interesting parts are what you've chosen to frame the question as and how you've answered it. In terms of presentation aesthetics, I can't really talk because this hasn't been a great one aesthetically. Presentations can be a really powerful tool to reinforce your message or a great burden if they're overwhelming. When in doubt, I prefer to keep my presentations minimal, icons replacing words where possible, and just one key message per slide. Signposting can help your audience keep track of where you're up to if they lose focus, and that means using things like headings that have meaning, a tracker for your slides, and colour, minimally, for emphasis. The last thing I'll mention is the difference between an oral and a written slide deck. If you're speaking, you want the attention to be on you and the words you say. You're telling the story and the presentation should just echo that. If you're not presenting though, your presentation becomes a choose your own adventure, and that's dangerous. You still need to provide structure and flow, but you don't have the opportunity to break down and guide your audience through complicated slides. They need to speak for themselves and say all the words you wanted to, but in fewer words. For that reason, if you're going to submit a written slide deck, it needs to be very structured with clear flow through each slide. The eye should track and the flow must be evident from the first glance. And that's it. I hope I haven't overcomplicated it, and I wish you all the best of luck.
Thank you to all of our amazing guest speakers tonight. If you have any questions for them or the UCCC team, please submit them via the Google form link that is now being added to the chat. You may specify in your submission if you would like a particular guest speaker to answer your question. Otherwise, your question will be forwarded onto a guest speaker at random. You may submit as many questions as you would like before 5:30 tomorrow. That is the 28th of July. All responses to questions will be released on the UCCC webpage on Friday, the 31st of July. So please keep your eyes peeled for that.
A final reminder for everyone to please complete our evaluation survey in the next 10 or so minutes to go into the running for a $25 Uber Eats voucher. The link is also in the chat. The winner will receive their voucher later tonight via the email address that they can form with.
If you have not yet registered to participate in UCCC 2020, please do so by midnight, Wednesday, the 5th of August. You can register as either a team of 2 to 4 people or as an individual to then be randomly allocated to a team. Together, you must present your solution in the form of a maximum 15-slide PowerPoint and 500-word overview report to be submitted by Friday, the 14th of August at 4:59 p.m. The UCCC team will then screen all submissions on a randomised and blinded basis and announce the 5 finalist teams by email at 9 a.m. on Friday, the 21st of August. On Wednesday, the 26th of August, via Zoom, all finalists will be invited to present their solution and engage in Q&A sessions with our panel of judges, whom you've heard from tonight. We encourage all participants of UCCC to attend finalist night to hear the very best innovative solutions to cancer survivorship care. The winner of UCCC 2020 will be announced at the end of finalist night on Wednesday, the 26th of August.
The winning team will win $1,000 and a summer research internship at the Victorian Comprehensive Cancer Centre under the tutelage of Professor John Emery. The team that places second will receive $500 and third place will receive $100. And that's a wrap for tonight. If you have any questions, please do not hesitate to reach out at us at our email uccc@achsc.org.au or via our Facebook page specified here.
We hope you have found the night very informative and now have some ideas to improve cancer survivorship care. A last big thank you to our wonderful guest speakers for their contribution to UCCC 2020, and we look forward to seeing your exciting proposals soon.
Excuse me?
Yeah, did you have a question?
Yes, I was just wondering if the recording will be uploaded anywhere that we can access.
Yep, it'll be on YouTube, and we'll post the URL link onto the Facebook page.
Yes, thank you.
No worries.